Hello, my name is Ravi Vij. I'm from My Cancer Haven. And today I have with me Dr. Joshua Zeidner, who is Associate Professor of Medicine, one of the leading researchers in the field of myeloid malignancies at the UNC School of Medicine. He's also Director of Clinical Research Commercial Integration in the Division of Hematology. And he's going to talk to us about how he uses Asciminib, a recent entrant into the armamentarium of drugs in CML. Welcome, Joshua.
Great to be here, and thanks so much for the invitation.
So, Josh, just before we start out, what is this new class of drugs, STAMP inhibitors, that Asciminib belongs to? We're all familiar with tyrosine kinase inhibitors for a long time in CML. How is this different?
Yeah, so Asciminib is a tyrosine kinase inhibitor, but very interestingly and cleverly, Asciminib belongs to a new class of tyrosine kinase inhibitors called STAMP inhibitors. And really what STAMP, the acronym stands for, is a specific tyrosine kinase inhibitor against the myristoyl pocket. So all the existing BCR-ABL tyrosine kinase inhibitors, imatinib, dasatinib, nilotinib, bosutinib, ponatinib, they affect this ATP binding site of the BCR-ABL gene or gene translocation, and Asciminib targets a specific pocket that is different from the existing tyrosine kinase inhibitors, and that's the kind of unique class of this new STAMP inhibitor class of drugs. Very interesting and exciting mechanism of action.
So I understand that it was approved based on a study called the ASSEMBLE study. Could you tell us about this study? What was the study design?
Yeah, so the ASSEMBLE study is really what led to the first FDA approval of Asciminib in the third-line setting for CML patients who have had two prior lines of tyrosine kinase inhibitors. This was a large randomized phase 3 study comparing Asciminib at a dose of 40 milligrams twice daily to bosutinib, which is one of the FDA-approved BCR-ABL tyrosine kinase inhibitors, both as a first-line, second-line, and third-line agent, bosutinib FDA approved for. So this study compared Asciminib to bosutinib in the third-line setting. So in order to be eligible for this study, patients had to have two prior TKIs, and those two prior TKIs had to either have been discontinued due to either failure to respond, relapse, or intolerance. So some of these patients did enroll on this study because they just couldn't tolerate, let's say, two prior lines of tyrosine kinase inhibitors. The primary endpoint of this study was a major molecular response at week 24, and that's really one of the more established surrogate endpoints looking for best response to these tyrosine kinase inhibitors. So it's really what a lot of the primary endpoints on some of our other large randomized studies in CML that have led to approval. There are a number of other, of course, secondary objectives, but the primary goal of this study was to see if Asciminib would lead to deeper responses, at least within the first 24 weeks, compared with an existing standard of care, such as bosutinib.
So what were the top-line results?
So overall, Asciminib led to significantly higher responses, really at all time points. Again, the primary endpoint of the study was at that week 24 mark, but there were multiple other time points that were assessed, including week 48, week 96. And ultimately, the bottom line is Asciminib led to a significantly higher major molecular response across all time points. Specifically, in the week 24 sort of primary endpoint setting, 25% of patients achieved an MMR on Asciminib, compared with about 13% with bosutinib. So it was about a doubling of a response rate seen with Asciminib compared with bosutinib, and that statistical significance really persisted throughout all of the time points assessed between Asciminib and bosutinib. So bottom line, higher responses with Asciminib compared with bosutinib in this third-line setting for CML patients.
How durable were these responses?
Yeah, so these responses were durable. And in fact, when the study looked at treatment failure or discontinuation due to progression or lack of activity, there were significantly higher amount of patients, or higher proportion of patients, I should say, on the bosutinib arm who had to discontinue for treatment failure. In fact, over 80% of patients treated with the bosutinib arm had to discontinue their agent over the study course due to treatment failure, whereas there was only approximately 50% of patients on the asciminib arm who wound up discontinuing over time. This proportion or durability of patients treated with asciminib was at least 50% for that 2-year time period that patients were assessed. So this is durable. These patients are responding more deeply and for longer periods of time compared with bosutinib.
So what do we know about the tolerability of this drug?
Yeah, so any new agent that is studied for CML, of course, tolerability, safety is really one of, if not the most important parameter as we assess new agents for this disease, because we have so many agents in our treatment armamentarium. In order to replace an existing standard of care of an agent that, say, might have a really good tolerability profile, it is the onus is on the new agent to really still be safe, well tolerated, feasible, and so forth. And I think the really exciting part of asciminib, the fact that the activity and efficacy seems to be better than an existing standard of care in the third line setting, let's say with bosutinib. What's even more exciting to me is that the safety profile is quite compelling with asciminib. In fact, there were more adverse events on this study on the bosutinib arm compared with asciminib, and that was kind of all causes, including grade 3 and higher adverse events. I think the main unique side effects that were seen at a higher rate with asciminib compared with bosutinib were some hematologic toxicities, including thrombocytopenia. That is one of the more significant side effects that were seen with asciminib at a disproportionately higher rate than bosutinib. About 22% or so of patients on the asciminib arm did have grade 3 thrombocytopenia, compared with less than 10% with bosutinib. Neutropenia rates were relatively similar, but a little numerically higher also with asciminib compared with bosutinib. The main thing with bosutinib, however, is diarrhea, GI adverse events, and increased liver function test abnormalities, increased AST, ALT. And on this study, those were significantly higher with bosutinib compared with asciminib. So slightly different side effect profile, but overall in the context, asciminib very well tolerated and less overall adverse events than bosutinib.
Another thing we always worried about with our tyrosine kinase inhibitors is cardiac toxicity. So what do we know about cardiovascular side effects here?
Yeah, so a cardiovascular toxicity is seen, as you said, with really all tyrosine kinase inhibitors. Some of them have a higher rate of arterial thrombotic events or other cardiovascular events than other TKIs. But the thing about CML is it is a disease of the elderly, and it is sometimes hard to really attribute whether a patient has a cardiovascular event. Is that related to the agent that they were on for their CML? Was it unrelated? Was there any association? And sometimes those are really challenging. On this study, there was a numerically higher rate of the arterial occlusive events with asciminib compared with bosutinib, but the numbers were really small. We were talking about 8 patients overall having some sort of arterial occlusive event with asciminib, compared with only 1 patient with bosutinib. And so based on this study, it's really hard to say that asciminib has significantly higher rates of, let's say, arterial events compared with bosutinib. Overall small numbers, but something that we definitely have to pay attention to in this disease.
I understand this drug also has activity against the dreaded 315I mutation. So could you talk to us a little bit about trial and the data in this regard?
Yeah, this is a very important, this is perhaps the highest unmet need in CML, as T315I mutations are one of the more common mutations that can be clonally acquired in patients on our existing tyrosine kinase inhibitors for CML. And it's one of those gatekeeper mutations where we have very limited treatment options. Currently, really only ponatinib up until this study has been the only effective tyrosine kinase inhibitor for T315I mutated CML. So this was a expansion study, a non-randomized, investigating asciminib for patients with T315I mutated CML. And in this expansion study, asciminib dose was escalated up to 200 milligrams twice daily. So the prior ASSEMBLE study looked at 40 milligrams twice daily, and this study escalated the dose for T315I mutated patients up to 200 milligrams twice daily. There was a longer follow-up analysis that was just published of 52 patients treated with this dose level for T315I mutated CML patients, really looking at activity and safety in this dosing cohort. Some of these patients did have prior ponatinib, which is really important since that is, I would argue, a really different biologic disease group if patients have a T315I mutated CML already exposed to ponatinib and then enroll on this study versus those who are ponatinib naive. So most of these patients actually were exposed to ponatinib as opposed to ponatinib naive. But interestingly, the response rates were assessed differently between those who were exposed or not to prior ponatinib. Overall, kind of the age range and the kind of prior lines of therapy are what you would expect in this kind of patient population with T315I mutated CML. These are generally kind of heavily pretreated patients, although this mutation, of course, can develop at any time. I think what was most compelling, exciting about these results, again, they're non-randomized, of course, but in this population with T315I mutated CML, just under 50% of patients treated with asciminib achieved a major molecular response, 47% in an ASH analysis, and I think up to 48% in a recently published long-term follow-up from this study, achieving a major molecular response with 200 milligrams twice daily of asciminib. And these responses really occurred quite quickly, mainly within the first 24 weeks, which is really important. In fact, the median time to achieve this major molecular response in those patients was about 12 weeks. So this is really exciting data that we potentially have another treatment in our armamentarium for T315I mutated CML.
And so it seems like the depth of response did vary by ponatinib naive versus pretreated.
That's right. Yeah. So, you would expect a patient population who's already been exposed to ponatinib and either not responded or not tolerated. Those are going to be more resistant CML patients. In fact, those are going to be patients who have been exposed to more lines of therapy. And as you would expect, the response rates were lower in the ponatinib pretreated patients. It was approximately 29% in the pretreated patients who achieved an MMR versus compared with over 50%, 58% in patients who did not have prior ponatinib. And I think where this fits in the pre or post ponatinib setting is still unclear, but there is a clear improvement in response in patients treated with this agent if they were not exposed to ponatinib.
So obviously a higher dose was used in this study. Was the side effect profile very different?
Not too different, and especially if you look at the hematologic grade 3 toxicities, thrombocytopenia, neutropenia were actually quite similar to the results on the ASSEMBLE study, which was given at 40 milligrams twice daily. Now, different population, different disease biology, given that these patients were all, of course, T315I, but hematologically seemed to be relatively well tolerated. Some of the more concerning side effects, at least with the higher dose, may be increased lipase and perhaps pancreatitis, which was also seen, on the ASSEMBLE study and with lower doses of asciminib. But there might be, a dose dependent, at least from a severe adverse event standpoint, with some of the GI related side effects. Cardiovascularly, very similar rates of very low rates, I should say, of cardiovascular events on the study, and similar to what was seen on the Assemble study, really only one patient with cardiovascular or cerebral events. So when you look at a smaller number, the percentage looks higher, but it does not seem like this higher dose really has a significant effect on cardiovascular toxicity.
So more recently at the ASCO meeting, there was the ASC4 first study, which is looking at moving this drug into frontline. So could you tell us a little bit about the study design here?
Yeah, this was a very impactful presentation at ASCO and was published actually simultaneously in the New England Journal of Medicine at the time of the ASCO conference. So this is a really impactful study, a little bit of a complicated study design. So this ASC4FIRST was an international randomized phase 3 study comparing Asciminib, and now the dose of Asciminib on this study was 80 milligrams a day compared with 40 milligrams twice a day, which was the dose on Assemble. So same cumulative daily dose, but given at a once daily version of 80 milligrams a day. And this was a randomized study to any frontline TKI physician's choice. However, the physician's choice had to choose from a randomization standpoint between imatinib or a second generation TKI. So there were two stratifications, randomizing patients to Asciminib versus imatinib or Asciminib versus a second generation TKI, which were pre-specified before randomization. But the primary endpoint was really twofold. One, comparing Asciminib to all TKIs, imatinib or any second generation TKI. And then there is a co-primary endpoint comparing Asciminib just to the imatinib arm. And there happened to be 50% pre-specified of those treated with imatinib versus those treated with second generation TKIs. So the first randomized frontline assessment of Asciminib versus our existing tyrosine kinase inhibitors. And again, the primary endpoint being major molecular response at that week 48 mark. So 200 for CML purposes, maybe not the largest study, but this was generally a large enough study to assess this primary endpoint. Overall, there were 200 patients enrolled on this study, 200 patients randomized across both arms, 200 on Asciminib and 200 divided into imatinib or second generation TKIs. So again, two different randomizations. I think overall, the age range was a little bit of a younger patient population, but generally it ranged, up to the upper 70s. And across all ages, really assessed on the study between Asciminib, imatinib, or second generation TKIs.
And so what were the results like?
So very exciting for the field of CML. Asciminib led to significantly higher rates of major molecular response at that week 48 mark across all TKIs, one of the primary endpoints, and also when compared with imatinib. In fact, when you stratify for the imatinib arm, again, half the patients got imatinib in the randomization, half got second generation TKIs. In the 50% group that got imatinib, significantly higher rates of MMR, so 69% with Asciminib compared with 40% with imatinib. And then when you look across the board, Asciminib versus any of the TKIs, 67.7%, just under 68% MMR with Asciminib compared with 49% with any of the TKIs. This was statistically significant across both primary endpoints. And, when you look against the second generation TKIs, this is nilotinib, dasatinib, bosutinib, these are all FDA approved as well for frontline TKI. Numerically higher rates with Asciminib, but not quite reaching statistical significance, 66% versus 57.8% with the second generation TKIs. But again, not powered for that second generation TKI. When you look across at early molecular response, even deeper responses like MR 4.0, MR 4.5, these are even deeper molecular responses than MMR. asciminib really led to higher rates compared with any of the TKIs. So a more effective, at least from a molecular response standpoint, agent than any of our existing frontline standardly approved TKIs.
So what were the side effects this in the frontline setting?
Yeah, so in the frontline setting, again, when we looked at asciminib seemed to have a better safety profile than bosutinib in the third line. So if we want to, replace or have a new standard of care for frontline TKIs, again, efficacy and safety, I think, are equally paramount to assessing, whether an agent in CML should be considered a standard of care. And again, to me, what I thought was the most compelling part of this study is that the safety profile also looked better with the asciminib compared with any of the TKIs. So all of our TKIs, imatinib, nilotinib, dasatinib, bosutinib, they each have a slightly different side effect profile, a different flavor of potential adverse events, some of which could be quite intolerable for patients. Across the board, these are well-tolerated agents, but in some patients, there are significantly higher rates of complications that require us to change TKIs. When you look across the board, just looking at grade 3 adverse events, combining everything together, asciminib had lower rates compared with imatinib and compared with second generation TKIs. In fact, 38% of patients with asciminib had any grade 3 or higher adverse event, 44% with imatinib, 55% with second generation TKI. So then when you look, well, were there any side effects that were more significant with asciminib compared with any of the other tyrosine kinase inhibitors? And some of the smaller numbers that I think are going to be important to tease out, the lipase increase is something that I think is specific to asciminib that may not be seen with some of the other TKIs. Whether an increased lipase actually leads to clinical complications of, let's say, pancreatitis is not clear in all these patients. But maybe that is one of the unique aspects of asciminib that's different from the others. Diarrhea, other GI-related toxicities, pleural effusions, those seem to be higher with the other TKIs. And then when you look at the hematologic toxicities, which the one thing from the ASCEMBL study comparing asciminib to bosutinib, thrombocytopenia seemed to be more increased, at least from a severe standpoint, with asciminib compared with bosutinib. But when you look in the front line compared with all the other TKIs, actually pretty equivalent grade 3 rates of thrombocytopenia with asciminib compared with at least second generation TKIs, higher rates compared with imatinib. But when you compare it to second generation TKIs, they were actually identical. Neutropenia, also lower rates of grade 3 adverse events compared with imatinib and second generation TKIs. These are not statistically significant, but numerically lower. Again, just corroborating and suggesting that these hematologic toxicities are not higher with asciminib, and that is really, really important because the agent clearly leads to a higher proportion of major molecular responses, better responses, and with a better safety profile.
So now moving to how are you incorporating this agent into your practice today? Obviously, we have data in the relapse refractory setting, it's approved. So in the relapse refractory setting, how do you use this agent today?
Yeah, so my current use is really restricted to the label of asciminib, which is in the third line setting. So I do use this agent frequently in patients who cannot tolerate 2 prior lines of therapy or have resistance to their prior lines of TKI. And at the third line setting, I think the ASCEMBL study gives us confidence that this is as good of an agent as any other TKI that's available. The study specifically only compared to bosutinib, but I regularly use this agent in the third line setting. In the T315I mutated CML patients, my current practice has really been to still use ponatinib in the setting of T315I mutated CML. However, the updated results of the Asciminib 200 milligrams twice daily in T315I mutated CML, the data that we just reviewed, looks quite similar to the activity and efficacy of ponatinib in the same patient population, really extrapolating to other studies like the OPTIC study that specifically looked at ponatinib at different doses. Now, it's really hard to do cross-study comparisons, but I do think now that asciminib is a very reasonable agent to use even before ponatinib in the T315I mutated CML setting. I think the side effect profile looks much more well tolerated than ponatinib, which has a lot higher, rates of arterial vascular events and so forth. So that's my current practice. I'm using it in the third line setting, and I'm thinking about it now in earlier lines for T315I mutated CML patients.
So obviously, yet to be FDA approved for frontline, but anticipated that it will. So before we get to how you will consider using it when approved, how do you treat your frontline patients today?
Yeah, so this is actually one of the more controversial aspects of CML, since we have so many agents FDA approved in the first line setting. We have imatinib, we have second generation TKIs, dasatinib, nilotinib, bosutinib, and really what the data to date has shown is that the second generation TKIs lead to a faster and more durable, deeper response compared with imatinib. Unclear from a long-term sort of survival, disease-free survival, discontinuation aspect, unclear whether those second generations really lead to better long-term outcomes. But certainly in the short term, there's a better activity. I tend to risk profile patients. I individualize my therapy for first-line patients. I look at their comorbidities, what other medical issues these patients have, and I try to tailor the first-line TKI based on their what agent I would not want to use for their comorbidities. So, for instance, dasatinib can have more pulmonary vascular events, could have more pleural effusions in a patient who has a lot of volume overload, heart failure, or other lung disease. I may not want to use dasatinib. If a patient has cardiovascular disease or hyperlipidemia or obesity, metabolic syndrome, I may be less inclined to use nilotinib. So I try to tailor it that way. I do use the SoCal risk score so that if a patient has really an intermediate or higher risk disease, I prefer using a second generation TKI because I'm confident that I can get that patient into a faster and deeper response. On the other hand, a patient that has lower risk disease that may have complications with some of the second generation TKIs from a comorbidity standpoint, I'd be comfortable starting imatinib. And then I do check their early molecular responses to switch if a patient is starting with imatinib and doesn't have that early molecular response, less than 10% at 3 months, in order to get them on the optimal TKI long term. So, I think the other thing just to briefly mention in this in CML is we're now thinking of long term, who can we discontinue these agents in 5 years down the road as they start their TKI. And we know that the longer patients are on TKIs and the deeper of a response they have, the more successful they are to discontinue their TKIs 3, 4, 5 years later. That data has evolved over the last few years, and it makes me a little bit more, I think it makes it more compelling to use a second generation TKI early so you can get the best, deepest, longest response so that you can then stop these TKIs 3, 4, 5 years later. And we're really replacing the dogma of being on these TKIs for life.
Is that your goal these days, to try to get patients off, or is it a patient by patient discussion? How do you tackle that?
Yeah, it's really a patient by patient discussion, and it depends on the setting. So if I'm taking care of a 29-year-old female who is thinking about having children in the next 3, 4 years, that's a big part of our decision of how we're going to start therapy and how we're going to get the deepest, quickest response so that we can discontinue therapy for life choices, pregnancy, and that type of thing. And of course, a younger patient, we're thinking of longevity. In fact, in 2024, the life expectancy of CML patients matches patients who do not have any cancer. A normal life expectancy can be achieved in patients who are diagnosed with CML. So we're thinking long term, and it is optimal for us to be able to stop these TKIs in patients 5 years down the road. Now, in an older patient population with lots of comorbidities, where the goal is really to keep the disease under control and maybe not rock the boat as much in order to get, at what cost do you want to get the patient into a really deep response that can have other, maybe complications of dose intensity and so forth. So those are patients that I'm a little bit less aggressive in maybe getting their disease under such optimal control so that I want to stop their TKIs. Those patients I may be more inclined to use imatinib and other tyrosine kinase inhibitors to keep things stable. Whereas, a healthier, younger patient population, we're thinking, how can we get this patient off therapy in 4 or 5 years?
And where do you think asciminib will land in your treatment practices if and when approved for frontline treatment?
Yeah, so I'm hopeful, optimistic based on the Ask for First data that this will be approved for frontline use, and I think the data from Ask for First, would compel me to use this agent really as a standard for frontline for all frontline patients. I think there's very few patients that I would not want to start with asciminib. The side effect profile again looked pretty good across the board for all different types of adverse events and comorbidities that, if you can get deeper, better responses than any of the existing TKIs, and the safety profile is as good, if not better, than the existing TKIs, I think that provides the impetus for this to be the new standard of care. Now, of course, there's going to be accessibility issues, financial cost. That financial toxicity concern, I think, is certainly an issue. I think those logistics will play a role in what we decide for each individual patient, but I'm not sure that there's any specific patient based on the data that I would want to use a different TKI to start with than asciminib. Now, the counter argument would be, well, we don't have long-term data of frontline use. We only have the initial Ask for First. What happens over time? Are there new mutations that are developing, or how are these patients doing in second line, third line therapy if they have resistance to asciminib? We don't have that data. So I think that is where the caution may be to adopt this as a standard of care for all. But until we have conflicting information that this agent, is leading to downstream effects that are, not optimal, I think that this is going to replace the other TKIs as a standard of care for frontline use, and might allow us to stop earlier than some of the other TKIs if you can get a really deep response, which this drug seems to do for longer periods of time. So I'm excited for the field. I think we still need, more data, of course, but I do think this will replace the existing standard of care once it's approved frontline.
I wish to thank you very much for that eloquent and extensive coverage of this exciting new compound, and I hope I can turn to you in the future as new data becomes available on this compound and others to help educate the audience. Thank you very much.
My pleasure. Thanks for having me, and it's happy to be back at any time.
Thank you.